Okay. So, thank you everyone for coming to this meeting. And today we are having our two senior vitreoretinal surgeons, Dr. Pranav Das sir and Dr. Demala Das sir. So, Dr. Demala Das sir is a senior vitreoretinal surgeon from Shankar Netralaya, Kolkata, New Town. And sir is going to talk about our eyesight meeting in DME, where the topic of Sir Dr. Demala Das is evaluating the need of change, evidence and insights on anti-VGF therapy. So, and let us introduce our second speaker, Dr. Pranav Das sir. He is also a senior veterinary surgeon from Roshni Eye Foundation, and also associated with Center for Sight, Kolkata, Elgin Road. So the next topic is on Dr. Pranav Das sir. So I would like to request the first speaker, Dr. Demala Das sir, to start the talk, sir. Sir, please start the talk. Yeah.
Can you see the slides?
Yes, sir, it's visible. Slide is not coming. The Zoom link is in the screen.
I'll just share.
And I would like to request, sir, once you start the presentation, kindly open the video for some minutes so that we can take the screenshot. Your
Okay,
video.
we'll do that.
Yeah, yeah.
I cannot open it right now because I'm sharing.
Okay,
I'm
sir.
not sharing
So
to the
after
other window.
sharing, you
Yeah,
just
I will do that.
yeah. Okay, sir.
Yeah. So thank you and good evening. And before starting, I would rather explain that Dr. Pranav Das is senior, very senior to me as well, and I always look up to him as a consultant whom I could always send my cases when I am in difficulty. So welcome, sir, to this meeting as well. And I'll be talking on evaluating the change, the need for change, with evidence and insights on anti-VEGF therapies. So we know that current anti-VEGF treatment of choice for wet AMDs are many. We have bevacizumab, ranibizumab, aflibercept, brolucizumab, and faricimab. There is no cure for the disease, but timely treatment can help achieve the NMD treatment goals of drying the affected eyes and inhibiting new blood vessel and keeping it in position for a longer period of time. However, in real world settings, significant gaps and challenges, both from patient, doctors, as well as the pharmacological point of views, poses barriers to achieving these goals. Now, we know that the introduction of antivascular endothelial growth factor has made a significant impact in the management of neovascular AMD, but there are certain challenges, as I said. And what are the challenges? So there are significant inter-individual differences in response to an anti-VEGF agent. What does that mean is that if we inject the same injection in two patient might have different response to the same anti-VEGF injection. And the availability of multiple anti-VEGF agents with different molecular configuration confuses both the patient as well as the doctor as to what to inject and when to inject. The response to anti-VEGF therapy, we know, are dependent on many factors. This includes the patient's age, lesion characteristic, lesion duration, the baseline visual acuity, and the presence of particular genotype risk alleles. And currently, there are no consensus as to how to classify optimal response or the lack of any optical response with these therapies. So, what do you mean by response to anti-VEGF? One is the primary response. Primary response means the response we get after 1 month following the last loading dose of injection. Means three loading, we give three loading dose. In faricimab, we give 4. After that, we call the patient after 1 month and see how the patient is responding. That is the primary response. The secondary response is any time after the 4th visit. It means like if we are having a treat and extend regimen, so we call the patient after the 4th visit and we inject, and then we call the patient after 6 weeks. That is, and beyond 6 weeks, whenever the patient comes, and we do an OCD as the secondary response. And response has two criteria. One is the OCT-based criteria, which shows the structural changes that happens in these days. And another is the best criteria visual acuity, which is actually the functioning of the retina in a whole. And both of these response are not the same. So you cannot guess how a secondary response would be by seeing the primary response. To quote an example, this is one of my patients who had given the first 3 doses, continuous doses of Eylea. And the initial thing shows subretinal fluid with double layer sign. And this is a classic case of a polyp which we had injected. And the patient had nicely scarred after the third loading dose with no subretinal fluid except for a scarred pigment epithelial detachment. But this is the secondary response. When the patient come after the fourth visit, means on the fifth and the sixth visit, you see the recurrence has again happened. So this is known as the secondary response. And as you can see, the primary response and the secondary response, there's a lot of difference between the structure of the OCT, and the vision was also dropped. Like it was 6.9 initially, now it becomes 6.18. And I had to inject again. So what is good response? So a good response, as I had shown you, that there will be any absence of subretinal fluid, intraretinal fluid, or reduction of the central retinal thickness to more than 75% of the baseline value. And what do you mean by functional? Functional is the improvement of visual acuity of more than 5 liters. What do you mean? But there's a ceiling effect to this. What do you mean by ceiling effect? Now, patients who have good vision, they are not going to gain much even with the injection. And most of the patients we get are either with very good vision or bad vision. The people who have good visions, they are not going to benefit much. If you give injection, the patient's vision might become 6/9 only. But the response to injection anatomically, which is seen through OCT, might better. Partial and poor response means that there will be hardly any change in central retinal thickness, and there will be persistence of subretinal fluid, intraretinal fluid, or little bit less compared to what it was initially. And non-response is when there's an increase in central retinal thickness and all subretinal fluid and intraretinal fluid, and the vision improvement is not much. So these are response to anti-VEGF in wet AMD. Now, switching to newer anti-VEGF agents, is it a hope or hype? Now, our main rival of aflibercept nowadays is faricimab. So they have studied both. Many studies are there which have studied both the injections together. What did they found out? Like faricimab actually have a 4 loading dose, but after 3 faricimab injection, or sometimes in 4 faricimab injection, in many of the studies, they didn't find any much improvement in the baseline visual acuity. But the anatomical changes had happened, but remember we had to give 4 loading doses, and it doesn't assure that the swelling or intraretinal fluid or subretinal fluid will not come back within a month or 2 months. 92% of the patients who had switched from aflibercept to faricimab discontinued treatment due to insufficient efficacy. What does that mean? Because the patient demands results. So if there is no change in visual acuity and patient paying a higher price, and there is minimal central retinal thickness changes, and most of them don't go beyond for Q8 intervals, what's the point in giving a higher dose of injection, which requires higher loading doses, and which doesn't assure you that the final outcome will be better than the aflibercept. And 75% of the patient who switched from aflibercept to faricimab remained on less than Q8 intervals for the baseline. So this is the advertise that was being done for any injection when they come, is that we can assure you that you need not have to inject multiple times. But this was not the case in case of the newer drug that has been presented. Like in this patient, I had switched to faricimab in between, but the patient had again developed fluid and came back to us within a month or so. This is after 4 injection of faricimab, and on the 4th visit he was all right, but between the 4th and the 5th hardly any, like he came back within 2 to 3 weeks. So like more than 6 weeks, the fluid came back. So this is one patient. Patient might have wow effect in others. As I said, inter-individual patients do have different response to similar injection. But this was one patient which shows that that injection didn't have a wow effect in this. So after 3 loading doses, significantly better visual outcomes were observed with aflibercept compared with faricimab. So this was one patient of polyp, one-eyed, where the patient had developed presented with subfoveal blood, where I had injected Eylea and no gas. This is the one in the right was immediately after 2 injections, and this is after the 3rd injection. You can see the fluid has completely disappeared. The subretinal blood has also completely disappeared. Subretinal blood, of course, will disappear with time, but the quicker resolution warranted that it goes away early. Similarly, in 6 months of real-world study with faricimab in diabetic macular edema showed limited visual gains. So could targeting additional pathways beyond the VEGF pathway be beneficial? So people have several different approaches were attempted in an effort to improve patient outcome. We all know that patient doesn't want to inject. We also don't want to inject multiple times in a patient with poor outcomes. So what was the additional pathways that were targeted? So the aflibercept had its own angiopoietin inhibitor like nesvacuumab, and what they found out is that targeting both angiopoietin and VEGFR1 pathways did not provide any additional improvement in vision. Similarly, additional pathway, the faricimab actually promotes VEGF-A block as well as angiopoietin block, and in TENAI and LUCRINT study, faricimab was non-inferior to aflibercept 2 mg for mean base-corrected visual acuity. So both were acting the same. Moreover, people have found out that ranibizumab and faricimab achieve similar level of plasma angiopoietin inhibition after 1 injection. Why is it so? Because the VEGF blocker in faricimab is actually ranibizumab. So that is actually acting, and any anti-VEGF activity will reduce angiopoietin inhibition. So after the first injection, the angiopoietin level will of course come down because the anti-VEGF is acting. So what's the point of giving angiopoietin in the next injection? So that is the study that they have found out. So as I said, the VEGF binding arm of faricimab is ranibizumab, and the role of angiopoietin 2 has not been established to show clinical effectiveness, because the anti-VEGF is acting. It's not the angiopoietin that is acting. It might have acted in a scene in the first injection, but it might not have that much effect in the second. So preclinical data suggests VEGF is the key driver of angiopoietin 2 production, and anti-VEGF agents can block VEGFR-driven angiopoietin 2 generation. So that's what. So anti-VEGF is actually acting. It's not the angiopoietin that is acting. So what is new thing the newer molecule is promoting is actually happening through the old agent of the newer drug, that is ranibizumab. So VEGFR pathway remains the master regulator in retinal diseases. So VEGF pathway is the master regulator. Why? Because all this inflammation, neovascularization, and retinal vascular leakage are being promoted by the VEGFR1 and also by the PIGF. And these are very key components of the inflammatory response cascade that can cause diabetic macular edema, that can cause damage to the retinal layers following CNVM or polyp. So these are blocked potentially by aflibercept. To summarize, aflibercept 2 mg already targeting the key ligands of the master regulator VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. And increasing the molar dose of any anti-VEGF agents may have the potential to offer patient more through the extended VEGF separation. That's why nowadays aflibercept 2 mg has become the standard of care for patients with CNVM or polyp, and also does a wonder in diabetic macular edema and macular edema because of retinal vein occlusion. Is the standard of care vision gains, durability, and safety profile across indication, and it targets the key ligands of the VEGF pathway. And now data from the Pulsar and Photon suggests that aflibercept 8 milligram has the potential for greater and longer lasting control of underlying disease compared with the aflibercept 2 milligram through sustained disease control. Thank you.
Thank you, sir, for such a wonderful, insightful presentation where your cases are also there as a real life scenario. And we are glad to have this presentation today evening. And now I would like to request our very senior Dr. Pranav Das, sir, having experience of more than 23 years in associated with Center for Sight as well as his own Roshni Eye Foundation. And sir is going to talk about the second talk, which is visual outcome in DME, assessing the efficacy of Q16 aflibercept injection. So I would like to request Pranav sir to kindly start the presentation.
Thank you, Saurabh.
Thank you, sir. Welcome, sir.
Good evening, everybody. First of all, it was nice presentation, excellent presentation by Dr. Devmallo. I have a question, Dr. Devmallo. How do you choose your anti-VEGF while treating a pure case of wet AMD, not PCB?
Sir, when I see a pure case and of course a naive case, my injection of choice, of course, have been the top two, the aflibercept and faricimab. But the problem sometimes arises when the patients, because of the affordability, couldn't afford these injections. Because I've seen in certain cases that it is individualized actually. I have seen wow effect with Eccentrics, I have seen it in Razumab, in other biosimilars. So you never know how the patient is going to respond. But out of 80-90 patients, like where I've given Eylea or faricimab, most commonly Eylea, I have got a very good response. But now they have removed this patient support program. I don't know how long we are going to sustain that. But I personally, I tell the patient that, see, these are the agent of choice. Now, if you want the other injection because of you cannot afford it because multiple time you can get it. So in treatment naive, I would always push for Eylea or Vabysmo. But suppose the patient has come after multiple injections where there's not much of hope, I offer him any VEGF, anti-VEGF that the patient wants. But for
Yes,
initial
regarding
phases,
that,
I will root for Eylea.
yes. I was also talking about that with the Saurabh that they have stopped the PSP, patient support program, and so it became a little difficult because Vabysmo in that way becomes a little cheaper. No.
Saurabh might have other things in his mind.
Yeah, sir. Actually, our next focus is on 8 mg. So
8
8
mg.
mg, yeah. Last time our management team has also shared with us that 8 mg has this Eylea for You program. So we will relaunch the Eylea for You program in 8 mg. For the now, we are waiting for the 8 mg to come. So meanwhile,
Okay.
we have done the new pricing for 2 milligram. That's you know already.
Okay. So coming to my presentation, I will be speaking on visual outcome in DME, assessing the efficacy of Q16 aflibercept injections. Not really Q16. This is more of a those patient who has been treated for a long time, how they fare when they've been treated with aflibercept injection, DME patients. So this is a sponsored program by Bayer. So as you know, it is expected that global burden of diabetes will continue to rise. Currently, as of 2019, there are 463 million population are diabetic worldwide. So it is expected to rise by another 51% to reach at 700 million. So 70 crore population will have diabetes by the end of 2045. So in South Asia, coming to our own region, now in 2019, there are approximately 88 million diabetic population. This is expected to rise by 74% to 153 million. And out of this, India encompasses almost 80% of the diabetic population, which is, so India is called as the diabetic capital of the world. And not only the rising diabetic population, the proportion of the patient diabetes who will have sight-threatening DR is expected to increase. As we know, diabetic eye disease is the leading cause of vision loss among the working age adults. As of 2020, it was estimated that 28 million people had DME. And if you see the projected number of sight-threatening deer was approximately 28.54 in 2020. It is expected to rise to 44.82 million by the end of 2045. So it is there's disproportionate increase in the sight-threatening diabetic retinopathy because of increase in life expectancy. And more alarming is that we know that lifestyle diseases like cardiac problem, diabetes, this affect the Indian population almost 1 decade earlier than the Western population. So having the complications of diabetes in our population is much more during the working age because of earlier onset disease. So they are likely to have the complication early in the working age. So that is more alarming. And vision loss is the most feared complication for the patients with diabetes. There was a survey among the American population. This survey was done at the diagnosis of diabetes. Patients are most fearful of the visual complication associated with the diabetes. So they were asked, which complication do you feel can hamper your lifestyle or can make you debilitated more? So 50%, 45, to be precise, it is 40% of the respondents said that this is a loss of vision. And cardiac, renal, circulatory, food or leg related and other problem comes later. So almost half of the population says they are fearful of losing vision if they continue to have diabetes. So effective treatment options provide the opportunity to improve the independence, productivity, ability to perform daily functions. So if we can have one line of gain in vision, it may help patients to read a newspaper, drive at night or under difficult condition. If there are 2 lines of visual gain, it may improve ability to perform near vision tasks such as cooking or using tools or increase patients' ability to work and perform the role-specific functions. And gaining 3 lines may help improve the color perception. So regaining and monitoring 20/40 vision or BCB of more than 70 letters may help patients to retain their driver's license. That is not seems very important in our country, but is very important, going to be very important for us also. A reduced risk of mental illness compared with the vision less than 70 ETDRS later. And there is potential for dramatic impact on the patient's daily lives. So we know that the efficacy of aflibercept treatment in DME is supported by the evidence from the robust clinical trials like the VIVID Vista, DRC, or NET protocol, not NET protocol T. VIVID Vista, they extended 3 years study which have shown that the possibility of improvement or it was effective in almost all arms of the aflibercept treated eyes. They are almost similar, ranging from 10 to 3 to 11.7 letters gain at the end of 3 years from the baseline. And DRC and .NET protocol T shows that this is more effective than other 2 molecules, the ranibizumab and bevacizumab. So patients with Vista maintain visual acuity gains for 5 years with a mean of 3.4 injection in year 5. So we know that initially it will require more injection in the first year, then the demand for the injection goes down gradually as the year passes. So patients were observed at 4, 8, 12 weeks intervals depending on the disease stability and substantial reduction of treatment burden through the 2 years. 25% of the patients required no retreatment in year 2, and 48% of the patients received 5 or fewer injections. So in second year, the number of injections needed were much less than the first year. So there are international recommendations and guidelines that recommends the first line use of aflibercept in patients with BCVA less than 69 letters, less than 20/40. Patients presenting with a visual acuity of less than 69 letters are in commonplace in our real world setting. So there are guidelines which shows the aflibercept is the drug of choice in DME with eyes baseline best corrected visual acuity below 69 letters, as it shows superiority to bevacizumab over the 2 years and over ranibizumab in the first year of treatment. And in patients with poor best corrected visual acuity worse than 612, aflibercept may lead to more rapid visual acuity improvement than ranibizumab over 1 year, although the difference was not statistically different by year 2 of the DRCN.NET Protocol T study. And superiority of aflibercept was noted in the group of participants with worse baseline visual acuity. This superiority of aflibercept at year 2 with gains of 18.1 liters in aflibercept, 13.3 liters in bevacizumab, and 16.1 liters in the ranibizumab group at year 2. So we can see there is clear superiority of aflibercept if the visual acuity at baseline was worse if you compare with the bevacizumab and ranibizumab. So there is evidence of possible difference in drug efficacy in patients with DME to the disadvantage of bevacizumab at a visual acuity of less than 20/50. Again, same thing. If the visual acuity at the presentation is worse, they do better with the aflibercept, even though there is a almost similar effect at the end of 2 years. Aflibercept recognized as the standard of care in DME is being used for DRCN retina network protocols evaluating anti-VEGFs in DME and DR. We know that protocol AB, protocol W, protocol B, protocol T, protocol SC, all of them are using aflibercept as a standard of care. Now coming to the Violet study. This evaluated the long-term benefits of aflibercept in patients with DME with different regimens after early intensive treatment in year 1 in the patients with aqueous. So all these patients were actually enrolled initially for the aqueous study. After intensive therapy of 1 year, they have been shifted to Violet study and they are observed for or treated for next 2 years. So this was a multi-center open-label randomized phase 3/2b study to evaluate the efficacy of 3 different treatment regimes of aflibercept 2 mg in patients with DME previously enrolled in the AQUA study. The patients were randomized 1:1:1. So equal number of patients randomized in these 3 groups. The first group received the aflibercept fixed dosing at 8 weeks, and the second group patient received aflibercept as treat and extend basis, and in the third group it was given as a PRN basis. At week 52, primary endpoints were continued treatment through the week 100, that is year 3 of the treatment. And the primary endpoint was the mean change in the best corrected visual acuity from the baseline to the week 52, and the secondary endpoints were changes in the visual acuity from baseline to week 100, and change in the central retinal thickness from the baseline to week 52. So it showed that there's gains achieved in the pre-Violet phase, this is the aqueous study, were maintained for the long term with a reduced treatment burden in the extended regimen group. So what they noted, though the mean changes in the best corrected visual acuity from baseline to week 10 were almost similar, a little better in fixed dose, that is 1.8 letter gain. That is after 1 year of fixed dose regime. So it's almost equal. So with treat and extend regime, they found the best result. So this is another study. It evaluated the outcomes of a 2-year proactive treat and extend regimen with the aflibercept for patients with DME. This was a prospective multicenter single-arm study assessing the efficacy of treat and extend regimen with aflibercept in patients with DME over 104 weeks, that is 2 years. Initially, all the patients received 5 doses at 4 weeks interval, followed by individualized treat and extend regime. And the primary endpoint was determined at 104 weeks. The primary endpoint was mean change in the best corrected visual acuity from baseline to week 104, and secondary endpoints were change in the best corrected visual acuity from baseline to week 52. So treat and extend with the aflibercept initiated in year 1 can provide clinically meaningful visual outcome over 2 years. So you can see that in year 1, the visual acuity gain was 9.1. Year 2, it was 9.4. At 2 years also, even after patient was shifted to treat and extend, the patient visual acuity maintained at the same level. And approximately 35% of the patients gained more than 50 letters at year 2. And out of these, 57% of the patients were on more than Q12, that is 3 monthly treatment intervals at the end of year 2. So this is very important here. See, at the end of 2 years, more than half of the patients were receiving an injection at more than 12 weeks interval. And mean number of injection was 8.5. That's because initially 5 doses of aflibercept was 4 weeks interval. So 8.5 in year 5, and the year 2 it is only 3.9 to maintain the same vision what was gained in the year 1 at the end of year 1. So this was an article by the Hirano et al. They also assessed the proactive individualized treat and extend therapy with the aflibercept in patients DME over 2 years. They also found almost similar kind of results. I'll not go into details. So there was almost 66.7% of the patients were on Q16 weeks treatment interval at the end of year 2. This is actually very encouraging. Almost 2/3 of the patients were been able to keep at 4 monthly dosing interval. So this is important. This is another study by Jade et al. They also evaluated the efficacy of proactive treat and extend regimen with the aflibercept of the patients with DME, where the patients initially received 5 injections in a 1 month interval. Then they were assigned the patients with the treat and extend regimes. And primary endpoint determined at week 52. Primary endpoint again was the mean change in the visual acuity visual acuity from the baseline, and mean changes in the CRT from the baseline proportion of the dry retina at week 20 and 52 at the secondary endpoint. And here in the treat and extend regime, minimum treatment interval of 4 weeks and the maximum treatment interval they kept at the 12 weeks. And there is a step of increase in the treat and extend with a 4 weeks interval. So that was important. So what they found there's 8.3 letters of improvement in the visual acuity from baseline to week 52, and 89% of the patients had a last injection interval of 12 weeks. That is, I don't know if whether achievable or not. This is very encouraging. A mean number of injection over the 52 weeks was 7.7, and proportion of the patients who reached disease stability at week 20 and could begin interval extension is 87%. So immediately after, I think it's the 5th injection, 87% actually could be extended beyond 4 weeks. And proportion of the patient, the dry retina at week 52 was 51%. So half of the patients were actually dry at the end of 52 weeks. So in prospective clinical trials, the majority of the patients with DME achieved more than Q2 treatment intervals after 2 years of proactive treat and extend with aflibercept. So this has been shown by the Vivim and Hirano et al. So in Vivim study, we could see 57% of the patients were on more than Q12 dosing interval at the end of year 2. And in the article by the Hirano et al., it is seen that 66, almost 2/3 of the patients were on Q16 dosing intervals at the end of year 2. So in summary, aflibercept can achieve clinically meaningful vision gains or maintain vision regardless of the baseline vision, and is the treatment of choice, particularly for patients with the baseline visual acuity of less than 69 letters or 20/40. An early intensive treatment followed by treat and extend regime in DME can also maintain the vision with reduced burden to the patients. So it is important to give the loading dose to all of the patients with the DME. And patients' factors beyond the baseline vision, such as duration and control of diabetes, can also have an impact on risk of vision loss in patients with DME. This is very important. And nowadays, I mean, sometimes we forget to take this note. If we should control the patient systemically well. Many of the patients are having very poor control, HbA1c very high, nephropathy, uncontrolled hypertension, low level of hemoglobin. All these actually matters a lot. So only pumping the injection is not the thing. We should see the patient as a whole, treat the patient as a whole, and then look at the visual acuity, retina, retinal thickness, OCT, and those things. So overall, early treatment of DME with good systemic control of diabetes and regular follow-up, patient can maintain vision for a long period of time. And aflibercept is the only bispecific VEGF fusion protein that is designed to trap the VEGF and placental growth factor. Early intensive treatment of DME makes maximize vision gains in the first year, and these can be maintained in the long term with a reduced treatment burden. I have shown many studies which have shown this exactly the same thing. With proactive individualized dosing, patients can maintain visual acuity gains with a reduced treatment burden after year one with aflibercept. And emerging real-world studies on DME have shown that aflibercept leads to good visual and anatomic outcome in clinical practice that are consistent with those reported in the clinical trials. Thank you very much.
Thank you very much, sir, for your wonderful presentation. And now it's a very insightful presentation, sir. Once again, thank you all of our speakers for coming to this meeting and such the insightful presentations. And now the floor is open for a discussion. So if any question from audience side or speaker
I
side-
have a question too, sir.
Yes, sir.
Sir, this is a patient who has initial CKD and just have started on by the nephrologist on medications, and patient has a CKD 1 stage. Would you give Eylea in this patient, because Eylea theoretically is the most toxic injection to kidney? So would you prefer Eylea or some other molecule here?
I will not have a specific preference for Eylea in this situation. I usually ask our nephrologist. Most of the time, nowadays I seek the clearance from the nephrologist. Now there is a clear, what should I say, clear difference in the opinion by the different nephrologists. See, one thing is sure, if the patient is on, as you said, is a grade 1 nephropathy, most of the time, many of us actually ignore, say 1.6, 1.7 creatinine, and we continue to give. And many times it doesn't actually matter in the long term. But and another extreme is the patients on dialysis. Those can easily take the injection. The question arises when the patient is having creatinine in the range of, say, 2.5, 3, 3.5. Those are the patients. And I don't know on what basis some nephrologists clear for the anti-VEGF injection, even the aflibercept, and some do not give permission for this injection. So if it doesn't give, patient is pseudophakic, you have one option to fall, that is the steroid injection. But if you don't, patient is phakic, patient little younger, I always refrain from giving Ozurdex injection. I don't give IVT anymore. So it's very difficult to answer this question. There, I will give little preference to ranibizumab rather than other molecule to start with in a naive patient.
Sir, and do you, so just like in PCV and CNVM, our drug of choice is Eylea, Vabysmo, or the newer drugs that are there. But in diabetes, would you go with these injections, or like you would rather go with the normal conventional biosimilars and anti-VEGFs that are there?
So see, in a diabetic patient, macular edema, I will always give offer for all these three at least. It's to be unbiased, aflibercept, Vabysmo, and ranibizumab, because the cost-wise also there is not much difference nowadays. So if I tell everything that this patient, if you take this, cost will be like this, our counselor is, they're educated enough to tell these facts. And I always try to give benefit of the injection. And by now we know that at least Vabysmo and Eylea are superior to ranibizumab. I think there is no question about that. Now one can say there's a mild diabetic retinopathy, diabetic macular edema, fresh case, whether you will start with ranibizumab. Why not give a better option if patient can afford? If patient cannot afford, then other thing. Demola, do you agree with that?
Yeah. My experience with diabetic macular edema and Eylea, if the patient had not opted for it, I don't push it. Means I don't push the patient, and most of them
Yes.
land up with biosimilars and DA. But the people who have taken this Eylea or Vabis, I've hardly had any patient with Vabysmo in diabetes. But whatever Eylea people have taken, and they are having good response. The problem is to put into
Yes.
their head that you require a long time treatment, because they want immediate benefit, and whatever is less costly, less costly, they are going for that because they know that multiple injections will be put. One problem that we face.
True.
On the top of it, Saurav has withdrawn this patient support program. So
PSP.
now patients are
Yes.
calculating how much loss they are having.
True.
Saurav.
Yes, sir. So, sir, it is very true. A lot of our doctors who are prescribing Eylea for a long time, they have told us that this patient support program should be there. So there is a loss we are already suffering, and to overcome that loss, we need HD also. So we are looking for the HD to come, and the same support program will be there, and with a more efficacious product. So on that note, sir, thank you very much, sir, both of our speaker, Dr. Pranav Das sir and Demala sir, for attending the meeting. And once again, thank you very much. And we are always looking for this the kind of opportunities in near future. Thank you, sir.
Thank you.
Thank you all.
Thank you.
Good night.
Good night.
Sir, can we close the room?
Yes, yes.
Thank you.